Okay, I'm looking around to see. There is no Pam who told us what's going to be here, so I'm going to be the co-chair of the Leadership Council today. Excellent. Well, welcome, everyone. Is first up our introductions?
Yes, I think it's been a while, so we want to do a round of big wins today and see,
Awesome.
see what you all are excited about.
Okay, well, let's start with Commissioner Manus. I don't know, I guess I'll just sit right here.
Sit down.
Sit down, take a deep breath. Exactly.
No, you can't do that.
Monterey County Commissioner, and I guess my big win, I think, was I was just appointed to the Board for Better Health Together.
Spoiler alert.
Oh, bless you.
I'm going to have you all use
I'm Tania Lightfoot. I'm here representing Pioneer Human Services today in place of Dan Sigler.
So we'd like to have our partners share just a big win of the last little bit of time or something you're excited about.
I think probably the transition of the Carlisle Care Center. So as it's winding down and trying to ramp back up, that's a pretty big win, I think, for us and the community. So thanks.
Mike Lopez with City of Spokane Fire Department and Spokane Valley Fire Department, and our big win is that the Right to Care program now has 215 referrals, people from 911 calls that have been transported to an urgent care rather than to a hospital ED. So moving right along with that project.
That's nice.
Misty Kinsman with Molina Healthcare. I'm not sure about my big win right now. I got a lot. I got all Eastern Washington.
Like you're moving to FIUC.
Yes, I am in North Central. It's my big win for North Central. We're hiring in North Central and moving on.
I'm Jeremy Jones from Planned Parenthood. Our big win is opening a new building November 20th.
Woohoo!
Construction is almost done, so it's exciting.
Hi, Kathy Olson from Molina Healthcare, and we've been knee-deep in starting to implement IMC in the North Central area, and I'm excited to hear that Spokane has chosen to go live in 2019, so really excited for that.
Hi, I'm Lois Bernstein with Multicare Health System, and I guess my big win is having a partner here, Chris Warity, to work on all these initiatives.
Chris Warity from Multicare Health System here in the Inland Northwest, and I would throw that right back. I'm grateful to have a person who has a lot of experience in leadership to learn and grow. And we're grateful also to be finding new avenues for the Multicare Health System here in the Inland Northwest to connect with our greater region. So.
I'm Dulcie Field. I'm the Chief Operating Officer at CBHA in Othello, Washington. We just are opening our newest clinic this week, so that's our big win.
Shirley Mikey with Passages Family Support representing Becky Bates, and our big win is we're working on supported employment and supported housing.
John Murphy from Passages.
Kathy Tham with Community Minded Enterprises, and our big win was the first annual Hands Across the Falls. We had almost 500 people right here who went across the bridge and held hands in support of recovery. It's pretty exciting. And then KXLY has just finished down at the Recovery Cafe at the bottom of the hill. If you ever want to stop in, we're completely redone.
I'm Kathy Hedgecock with Second Harvest, and I think I'd say our big win is we finally have somebody lined up to start updating our bus that was donated by STA. That's going to be our new walk-through mobile market for high-need neighborhoods here in Spokane, just trying to increase access to healthy food. So.
Yay.
Aruna Bhuta on Advisory Council of Area Agency on Aging, and our big win is rollout of Initiative 2, supporting people so that Medicaid enrollment can be delayed and people can, unpaid family caregivers can get the supports in the community.
And it sounded like it's been a fairly smooth rollout.
My name is Terry Koski, and I'm the president of National Alliance for Mental Illness Spokane, NAMI Spokane. And our big win is we had a fundraiser a couple of weekends ago, and we did a net profit of over $7,000, which for us is the biggest fundraiser we have ever had, most successful one we have ever had. So we're very happy about that.
I'm Jean Kindam, and I'm also with Aruna on aging and long-term care, and my win is the same as hers.
I'm Sarah Bullock-Dorn with United Healthcare. I'm still kind of coming off the high of all the information from the Public Health Association conference last week and all the good opportunities that might come out of that.
Good morning, Torney Smith, Spokane Regional Health District. Our big win is just beginning. It is working jointly on the community health assessment work that is ongoing. And we've had 3 of 5 groups meet for the first time. Roughly 50 people per group to talk about healthy people, the environment, public safety, housing and transportation, and one other. Education, thank you.
I'm Gina Drummond with Hospice at Spokane, and I guess I'll say one of our big wins lately is just celebrating our 40th anniversary with our team members and our donors and supporters and volunteers.
Good morning, Danielle Cannon with Coordinated Care, and I guess our big win is we're one of the 3 that are going to be rolling out IMC in North Central, so we're very excited.
I feel like I've got a new thing here. It's now IMC, not FIMC. So
right.
Just all start to transition to that, which is integrated managed care for those.
They took the F off officially.
They took the F off. Oh my gosh.
Yeah.
Here
it is. Fully. Because like long-term care is.
Sharice Pope Excelsior, Chief Business Officer. We were fortunate enough to bring on a family physician to integrate into our behavioral health clinics. We're very excited about that.
Andrew Hill with Excelsior. Let's see, in October we celebrated our 35th anniversary, and I think another big win is the collection of diversion programs that we've rolled out over the last few years. We're seeing great success in those and excited to partner with people to make sure we can expand those.
Hi, John McCarthy with Spokane County Medical Society, the UW School of Medicine and Native Project. So I've got 3 there. It's easier to choose a big win if you have 3. I'd say from the County Medical Society perspective, we've been doing a revisioning, and we figured out how to reinvent ourselves and have done that and are starting to implement that.
I'm Bob Ray, Community Health Plan of Washington, and I guess my big win is being able to attend this meeting for the first time today. I'm excited about that, and I'm also, I think, from the CHPW standpoint, I think we're pretty excited about the fact that this fall, with the annual enrollment period for Medicare, we've expanded into 6 new counties for the special needs population.
Any in our 6-county region here? Just to put you on the spot. You can have your win regardless.
No.
Okay.
Unfortunately.
That's okay.
We're already here.
Whole state.
We're already here. We're already here.
Just like to be, in all 6.
I'm sure we're in all, but we are in a
Not all.
I'm just going to keep pushing.
Hi, everybody. Kat Latte, Community Health Plan of Washington, and I think our big win is being able to have Bob here. Nice to have a compatriot with me here, as well as I think big win is there was a recent report that came out around Southwest Washington regarding the impact that integrated managed care has had since it's been rolled out in Southwest Washington. And I think that it's a really great report to show the success that we're seeing around what integrated managed care can do within a region. And so that would be the big win that I think as Spokane region is moving into IMC as well, taking a look at that report and understanding what those impacts are. It's great for this region as well.
Hi, Regina Malvo with the YWCA, and this is my first meeting, so that's a win. But really big win, thanks to Lance and his extraordinary grant writing skills and our program staff and their great reputations. We just received a $500,000 grant from the Office of Crime Victims Advocates, and it's actually only a 20-month grant, so that's an awful lot of money for 20 months. But there is, and what it's intended to do, what it will do, is provide prevention funding to keep victims in their homes. So instead of a victim having to be evicted because she can't stay there and having to come into shelter and then us trying to refine her, usually her housing, the bulk of this money, probably 95% of it goes directly to client support services. So very, very, very excited about that. Currently, as I understand it, there's only $50,000 in the county for that function, and so this really helps meet a tremendous need.
And I'm Lance Laurier from the YWCA also. And we partnered with Transitions on a transitional housing grant from the Office on Violence Against Women. It's a 3-year grant, and we just heard at the end of September that was funded. So more emergency transitional housing options for victims. And my big win is that Nadine Van Stone just walked in.
Thanks, Liz. So Nadine Van Stone from Catholic Charities, and our big win is that we will take our first families at Rising Strong on Monday. So for those of you who don't know, it's family-centered treatment out at the old Holy Names Convent, really keeping families together while they get treatment. Kids get services, everybody gets services. We're partnering with the Y, with Excelsior, with YFA, with Tony at the Regional Health District, so great partnership. Thank you.
Awesome. All right.
Good morning, everyone. My name is Carly Levitz, and I work with the Center for Community Health and Evaluation, and we are the evaluation partner with the HCA for the ACH initiative across the state. And my big win is being able to come out to Spokane. We're Seattle-based. We do our best to see as many ACH meetings as possible. Sometimes I'm on the phone, but it's great to be here in person. Some of you, I think, are on multiple ACHs or even just in your role here at VHT Leadership Council. If you have any feedback or anything, if you want to just bend my ear about something, just feel free to come talk to me.
Good morning. My name is Paula Williams from Operation Healthy Family. And our big win is that we are we are quadrupling the capacity for dental access in Spokane. It's very exciting.
Hi, I'm Lilia. I'm also from Operation Healthy Family, and our big win is with our program Brush for the Future, we will have 600 students brushing their teeth in just one school.
Hi, Dawn Sayers with Qualis Health, and our big win is we have a big conference in Moses Lake tomorrow for this side of the state that went really well on the west side, but it is all about integrated care and working towards that. So we're really excited to meet a bunch of people and go to that all day tomorrow.
Raise your hand if you're going to that conference. Woohoo! Yay! They'll still be on stage.
So no booing, right?
I'm worried about
All of the fanfare that he'll get.
I know, that's true.
So we're going to I'm going to walk through the folks that are on the phone, and I'm going to call your name, and you're going to tell us who you are and what your win is. Let's start with Amber.
Hello, Amber Moore from Kaiser, Washington. Sorry, I feel like I'm on echo.
You're doing okay on our end.
Okay, good. I'm just hearing myself. I've been with Kaiser for a month now as their new Director of Medicaid Strategy, so I've been working to kind of figure out how best we can plug in a little bit more robustly than it seems like we have the last couple of years in the ACHs where we are most present. So my big win is showing up on this call and hopefully getting Kaiser more engaged.
Excellent. Welcome. Amber Johnson, we'll go to you next.
Good morning, everyone. Amber Johnson, SNAP, and our big win is we have a signed ALSA contract in place and are looking forward to seeing our first clients.
Woo! I love it. Betsy?
Betsy doesn't have a mic. Excellent. The win is workshop on transportations this month. Thank you. Special mobility services. Okay, moving down, Blake. Oh, Blake, do you have a mic? Maybe we'll go to Brian and we'll come back to Blake.
How's that?
Excellent.
All right, good morning. Blake Redding here with Spokane Treatment and Recovery Services. Big win for us is we're expanding our highly successful hospital diversion program, and we are also adding an additional sobering unit to accommodate the need in the community.
All right, that's a great win. Brian?
This is Brian, can you hear me?
We can.
Perfect. Brian Sandoval, Yakima Valley Farm Workers Clinic. Big win for us. We just got a grant and we'll be rolling out a telebehavioral health initiative that'll also provide MAT services to our population, and we hope that'll serve about 13 to 1,500 Washingtonians.
Excellent. And Yakima Valley here in Spokane is Unified Community Clinics.
Unified. Yeah, Unified Community.
Just want you to make sure that you're all covered here. Carol, you want to introduce yourself?
Yes, I'm Carol Plisky, the Executive Director at Partners with Families and Children. And our latest big win is we too were granted a $500,000 grant from OCVA to provide additional services to child victims and their families.
Oh, excellent. Jack.
Hi, I'm Jack Davies with the Northwest Rural Health Network. And our big win is, I think, just getting started on a rural palliative care initiative. 5 of our members are entering that with the State Department of Health.
Excellent. Jenny?
Hi there, this is Jenny Smith, Newport Hospital and Health Services and the Pondere Health Coalition. And I would say that our big win is having Pondere County represented on the Better Health Together board. Super proud of my dad.
I love that. That makes me so happy.
Thank you.
Jim, do you want to introduce yourself?
Hi, this is Jim Jackson with the Department of Social and Health Services, and regrettably, I don't have a big win to report today, but glad to be on the call. Thank you.
Excellent. Julie?
Good morning, Julie Honkamp from SNAP, and I guess I'd share our big win is in just 4 days, we've made over 5,000 appointments for energy assistance. So a lot of folks out there looking for some help with a heating bill this year.
Excellent, excellent. Both staggering and grateful for the work you all are doing. Libby?
Hi, this is Libby Hine from Children's Home Society of Washington. Our big win is we're expanding our Wendy's Wonderful Kids program throughout the state. This is a program that helps children in foster care find permanent homes. So we're pretty excited about that. We're having a huge expansion.
Excellent. Lindsay?
Hi, this is Lindsay Roux-Evivar with Chaz Health. Our big win is we are now offering group prenatal care. This is something we've been working on for a while in partnership with the March of Dimes and Centering Healthcare Institute, and we are scheduling our first patients for December.
Oh, excellent. Mike?
Hi, this is Mike Weiser, also with Chaz Health, so I will be first since Lindsay already gave one.
Excellent. Peter?
Good morning. This is Peter Adler at Molina Healthcare and a BHT board member. Our big win is in the Spokane region and northeastern Washington is the celebrating BHT's 4 new board members, including Mike Manis, and the decision of the counties to move to a mid-adopterhood in fully integrated managed care. And we, like others have mentioned, are excited about going live on January 1st with fully integrated managed care in north central Washington and building on our successes from the southwestern Washington region.
Excellent. Sandra?
Hi, this is Sandra Suarez from Yakima Valley Farm Workers Clinic, Unified Community Health Clinics there in Spokane. And my big win is just being able to participate in the meeting today, even though I can't be there physically. So thanks.
Oh, excellent. Shannon, I think you are rounding us out here.
Okay, this is Shannon with the Mary Group, and our big win is that we are onboarding our new tribal liaison.
Oh, fantastic. Excellent. Well, it is so delightful to see some friends who have been with us for this very long ACH journey to date, as well as a number of new folks. I'm especially pleased to see so many of our substance use disorder treatment partners engaging with us. We've got a lot of work to do together. Is this me now? I'm going to just keep going. I'm just going to keep going. Well, we've had quite a last couple of months as we get sort of ready for this implementation phase of the Medicaid waiver, and we're super proud that we made it through 2 rounds of certification with the Healthcare Authority, earning the region $6 million for that. As we heard throughout the big wins, so pleased that the 6 counties came together and decided to move into integrated managed care on January 1, 2019, which means we have a ton of work to do to get ready for that, on top of an awful lot of other work. So those are really sort of big, monumental steps for the region. As we have been preparing for really the waiver work, one of the things we wanted to do is round out our board. So we have expanded a little bit and added some really high quality leaders to the board, as well as saying goodbye to a couple of folks who are transitioning into other chapters. Dean Larson, who was with the Spokane Medical Society, as well as Christine Barada, who I think is on her T-minus 6 days still. I get to be retired phase. So BHT now has 9 board members. We're going to make them work extra hard next year. 19? What did I say? 9. Yes, we got bigger, not smaller. So we wanted to spend a little bit of time with what felt like a pretty monumental decision at last, I think it was only last week. I'll just say last month, but last week's board meeting, where we made our final selection on our 6 project areas. Let's see, I want to see if I have the old. No. So for those of you who've been with us for a while, you remember the old triangle toolkit that had the domain 1 and the 4 projects and the 4 projects. And so we've spent a tremendous amount of time over the last several months trying to figure out how our region should really think about this project integration. And we are lovingly referring to our regional portfolio of We Love Babies and Teeth, because you will see there's a couple of project areas that are missing, but we wanted to make sure nobody thought that we didn't love babies and teeth. So for now, that's going to be one of our themes. I'm going to just walk, because we've got a number of new folks sitting with us, just a little bit of who this ACH is and how we're thinking about work. This vision statement and our guiding principles have been really developed over the first 3 years or so of that ACH through a variety of different mechanisms. We have brought this back to this group a number of times, and it's really cool that over that 3 years, there really hasn't been any drifting in terms of our goal is to really build a whole person integrated community health system that really takes into account all of our community's needs. In our guiding principles, I think one of the ones that just continues to be so important to us is that this is really locally led, and that we want to try and get as localized as possible. So a really robust rural set of coalitions, as well as neighborhood level work. And, you know, just because it's really fun, also to point out, we don't want Olympia telling us what to do. These 5 regional health priorities will look familiar to everyone, and we've spent a lot of time trying to really look at the data and figure out if we were going to move the needle on some core target populations, who would those folks be? My very fancy theory of action that really at the core of the work that I draw your attention to is this integrated healthcare system that is connected with our integrated social determinant of health system, and that in between those two systems are a number of really important efforts we need to make around diversion, transition, and community-based care coordination. As you all know, the state was awarded a Medicaid transformation demonstration waiver. There are 3 initiatives. This one's, the ACH initiative is really in Initiative 1, and the elements are really reflected here in terms of building out our community capacity, redesigning our care delivery system, and focusing on prevention and health management. I think as we start to think about this demonstration work, we are getting clearer about how we really want to frame out this work. And though there are 6, 8, depending on how you want to think about it, project areas, these are really the goals and the way we want to organize the work. So whole person care, linking healthcare and social determinants, reducing health disparities, and importantly, how we're going to pay for all of this. So this transition to value-based care, both in the healthcare setting, and increasingly we're seeing it even on the social determinant of health side of things. I'm going to just flash this up quickly so we remember who our Medicaid population is. I think it is just always important to keep ourselves grounded in this. So on the left side you see total population, Medicaid population for each of our 6 counties in our region, and then on the right side, the middle column is for BHT. We have, so one of the big decisions that the board made last week after lots of consultation with many of our partners and through our engagement structure is that we will really have 2 collaboratives, a rural health collaborative and a Spokane collaborative. But what was really important is that we recognize that each of our rural counties are really their own system of care that connect more specifically to the Spokane area of services. And while there is no doubt that there will be some efficiencies in linking both the technical assistance and infrastructure work to a rural collaborative, we really believe that we need to build on the local health coalitions work that have happened in each of these five areas. So what's important to note about this is this will be the primary mechanism with which providers will earn waiver dollars. Okay? I see a lot of head nods, so that makes me feel like this doesn't feel super surprising. We have not formally approved this, though we expect to next week, our general funds flow approach. So this is really, this slide is designed to demonstrate where we're going to put a bulk of our investment. So we have already decided that the ACH management will be capped at 5% of the total project dollars earned for the region, and that we're going to set aside 10% of those dollars to a community resiliency fund. We've got a lot more work to do on the community resiliency fund in terms of determining how those dollars will be allocated, but the essence of it is this is really where some of our social determinant of health investment can come from in how we're linking the healthcare system to the rest of the services that we're going to need. I want to make sure that it is noted that this is not just the social determinant of health pot. We see a place for many of our partners to be involved in the collaborative structure as well. But a bulk, so 85% of our dollars really will be sort of provider level investment. So it's both infrastructure we may purchase on behalf of the region and invest in partners, as well as specifically collaboratives earning dollars based on a number of different areas. And you can see sort of our working levels of how those payments might be earned or distributed. So maybe I'll take a moment there because everybody likes to talk about money and see if there are any questions on that particular slide. I would also note nobody has made any decisions on who is going to get any money. So nobody needs to freak out that you've missed any of those decision points at this point. We really see the collaborative development over the next 6 to 8 months being building out the implementation plan, developing a set of assessments so that we understand how to get the best leverage for those investments. Really? No questions? What about on the phone? I knew it. I can always depend on Kat to have a good hard question.
So my question, this is Kat from CHPW, and my question relates to the regional partner investments and the collaborative investments. And so seeing the workforce development and HIE and HIT and population health management, which we know sit within Domain 1 area, but of course are specifically targeted to the projects and the build out and the capacity development that providers need. And so seeing those also within the collaborative investments as well, which is great. And so I guess just wanting to see a little bit, just some thoughts around how you see those two pieces interplaying with each other, because providers might want to understand a little bit more around, well, what type of workforce development and population health management are they investing in with their dollars versus what's happening at the regional partner investment level and how's that directly impacting them?
That's a great question, and I could pontificate a little bit, but I think there's a lot still to be determined. As we shared last Leadership Council, there has been a sort of shrinking of the pot of dollars that are available for all 9 ACHs to earn. And so probably an increased focus on some of these Domain 1 areas around HIE and HIT, certainly the population health management side and workforce development side. Where can we get a leverage across the state, and where can we put more pressure on the state, not just the healthcare authority, but other state agencies who are doing work on this to align with sort of statewide needs. So I think there's a to be determined link there. I think what's been important to the discussion so far, and I would say our waiver finance work group has only met twice, so there's not a lot of detail to this. That's sort of a coming phase, but it was really important to us to say there are some things that we're going to invest in terms of, you thought of community health worker training or that type of thing that we would invest in on behalf of the region. But there might be other things like a rural health provider might have a need for some training with an MA that isn't something that every single healthcare provider in the region would need. So we wanted to make sure we gave ourselves enough flexibility in our model development now to be able to address that, and that, you know, this is a lot more than the $60 or $70 million we have to earn. This is really going to be about how are we going to braid together those resources, and a really important part of it is going to be in the next 6 months or so as we do that assessment of, in order to make these type of clinical transformation investments, the workforce piece, and really the HIE piece is going to be, in my mind, probably the make or break. I think there is a lot of will and good intent around the actual clinical practice transformation, but some of these pieces are going to be important, and I don't think we have our arms wrapped around that. Other questions or comments? Nothing from the, excellent, okay. So this is, I'm going to walk us just through a little bit of our thinking on our project selection and how we got to our decision of 6 projects, and then just make a few highlights on sort of the work we see within each of this. As we thought about 8, and I think through the Leadership Council, through board discussions, certainly through our Rural Health Coalitions, there has been a worry of being spread too widely and not being able to have enough impact. And so one of the ways we looked at this was, oh, Carol has a question. Let's unmute her. And oh, how will the collaboratives initially be formed? That's a great question, and we have been doing some specific thinking about this. So in our rural communities, we're really lucky because our health coalitions sort of are the right partners doing the work at the table. There's probably a little bit in some of the counties to further engage some critical partners. But through our health systems inventory, our care coordination, and some analysis on the larger Medicaid billers in the rural counties, we think we've got an idea of who those partners are. Spokane County, as you can imagine, is just generally more complex because there's so many more providers. And so over the next probably month or so, we will do a series of sort of informational overviews of the collaborative to get a sense of who's interested in. It's really a opting in set of partnerships as we look at the work. Does that answer your question, Carol? I'm going to hope so. So one of the things as we were thinking about project selection was how many measures. So increasingly, it's important for us to think about how the region earns the money, which is based on the something like 36 measures that will be accountable for, and then how will the collaboratives earn dollars. So one of the things we wanted to look at was what level of reporting and measurement will we need to have. The second thing that we did quite a bit of analysis on was the scoring matrix with which a region earns money based on paper reporting versus paper performance, and the metrics of sort of how far do we have to go to see, sort of where's that sweet spot. And what we found was that we thought that the best financial equation was really at the 6 projects. The paper performance achievements with the 8 projects really was us assuming we could only meet 75% of the metrics. I think it's unlikely this region would perform that poorly, but we were trying to sort of get a sense of, you've got to build a lot of infrastructure to work across 8 project areas and a number of these different metrics, and really came to the conclusion that the dollar equation made the most sense on 6 projects. The other piece that we really looked at was just community input and where there was community energy and so forth. So this just walks you through our sets of engagement with the community. So in January, right after the waiver was signed, we did a overview of all 8 project areas and asked the board to sort of vote on how many do you think we should do. And there was definitely a intensity around be focused and be very successful. What we didn't know at that point, which we learned sort of mid-March, was that if you only did 4 projects, there was a lot of sort of built-in penalty in the evaluation side of it. So that sort of had us go to, well, then we should do all 8 because we wouldn't want to be penalized for not doing enough. Then we worked through this letter of interest in our community pitch process, and from our perspective, from a staff standpoint, we thought, well, one of the ways we could maybe get a little bit more focused if it turns out there's no community energy around a particular project area, or if we find out there's really interest only in a couple of counties, not all of them, that would be another way. What we found out was actually there was interest in all 8 project areas across all 6 counties. So it wasn't really a focusing result out of that. Then this summer we conducted our health systems inventory and our care coordination inventory, and this got us a little bit more focused on the essence of some of this work is really this integration to try and get to whole person care, and how we link together the healthcare system with the care coordination side of things. And interestingly, what we found is we started to frame out the preparation or the using this investment to get the community ready for value-based payments, that while there was a tremendous interest in the clinical practices tied to oral health and maternal and child health, some of the models that were in the toolkit didn't rise up with, I as a health system can see paying for that set of services in my future value-based payment contracts. So that was the first sort of point that we were like, okay, that's sort of interesting. There's a clinical integration piece of which there's either great work happening or there was a lot of interest in being able to expand that. And then over the last month, we spent quite a bit of time in a number of our sort of work groups, so the Leadership Council, the Waiver Finance Committee, the Tribal Partner Leaders Council, and then we hosted a specific provider focus group session. And in general, we were seeing a consensus around 6 that sort of gave us enough focus without really risking dollars. So that really, I'm going to move through that. That really moved us to the staff's recommendation that we select 6 transformation projects. And as we went through the board discussion, for those of you who didn't call in or weren't in person with us, a integration of the clinical elements in maternal and child health as well as oral health. And this started to feel really important, hence the We Love Teeth and Babies frame in how we actually do the work. And that the essence of these collaborative models is really this integration of behavioral health services and physical health services, and linking together this opportunity to really transform our clinical practices with some of these things. And so I love using the long-acting reversible contraception, or one key question as an example. While we're building out how you're going to also do depression screens in a primary care setting, you could also be asking these additional questions or doing these additional screenings. And it will be most effective from a change management process, we would hypothesize, to not sort of kill people with monthly or yearly change, but like, let's actually move to transformation and build out a solid process for being able to do that. So I think you'll see as we move into our project development and implementation planning, this really sincere desire to transform the system with enough incentive built in to really get some different types of care models being delivered. How are we doing on time? Do you want?
Yeah, we have more time.
Okay, excellent. Then what I
start talking at 11:30.
Oh my gosh, I got 35 more minutes. Fantastic. Well, maybe I'll be a little bit faster. I'm not sure everybody wants to listen to me for quite that long. But for each of these 6 areas, I'm just going to run through a set of overview that will give you a sense of how we're thinking about this work. And my hope is that depending on which part of the partner group you are, you will see both your feedback and your role starting to be visible in here. So with bidirectional integration, I think there's a couple of things to sort of note at the outset. So one, we really imagine this being a target of every Medicaid beneficiary having access to the right set of services in the right setting. But because we want to be slightly disciplined in how we approach this, we are going to start our target population with our highest volume Medicaid providers. So just so nobody worries, everybody sitting in this room and on the phone would fit into that category. It turns out in our region, you all are pretty well connected, and we think we generally know who you are. But this idea that, and I don't really even know that this is actually true, but that there is hypothetically some providers who are just seeing a handful of Medicaid beneficiaries. We are happy to have their involvement, but we really are trying to look at the volume side of this. The second sort of target population for us is co-occurring conditions. So individuals who have either mental health or substance use disorder needs as well as chronic disease. I think when we start looking at how we're going to bend the cost curve and really have sort of that population level impact, that's a smart and good target population for us. In this project area, there are a couple of sort of core models we have to be able to speak to as a region. And through those conversations, we've really identified that no one model is going to work for the whole region. So each of the collaboratives will really be charged with developing what is their approach that pulls in, you know, elements of the BREE collaborative or the collaborative care model, or, you know, integrating primary care into the behavioral health setting. You can see down here the types of metrics that are going to be tied to this particular project area. In years 1, 2, and 3, a bulk of our dollars are in this paper reporting. So number of practices implementing evidence-based approaches, we will be able to say there are X number in our region doing that. That will help us earn those dollars. The other thing that I would sort of add is, as we're thinking about this, and this is where we have worked to try and link up the oral health and the maternal and child health, is in some of these required activities. So talking about primary care practices, putting varnish on the teeth, making sure that any woman of childbearing age is asked, would you like to be a parent in the next year? And if the answer is no, that they're getting directed to some family planning services. There are a couple of ones that have bubbled up through our conversations around end-of-life planning or palliative care. And then, of course, you'll see sort of built into many of these the community care coordination work. Our region for this particular project area could earn up to $20 million, which, when you think about what we're trying to do, is not even close to the amount of money that's going to be necessary. And so we're just starting to look at, again, this idea of how are we weaving together all of the different funding sources that will be available. We have made a policy decision that the fully integrated managed care incentive of $8.7 million will be aligned with the integration of physical health and behavioral health. We think there's a lot of exploration with, as the BHO transitions into integrated managed care, how are we taking advantage of those reserves in a really appropriate way? So the BHO and the county commissioners will have a lot of opportunity to see how those investments could be made. Certainly our MCO partners have a vested interest in making sure, as we move into integrated care, that their providers are well positioned both to deliver whole person care, but also to be ready for value-based payments. So thinking about what they would naturally invest in, so we're not sort of using dollars in ways that it should be used out of this bucket versus that bucket. And then finally, I think we're seeing some really interesting philanthropic support starting to show up. We have heard that there's some national funders who've sort of selected Washington as a ripe market for reducing unintended pregnancies and the utilization of the one key question. They're talking big money. You know, I've seen no check yet, but we're happy to sort of engage. So with some of this work, could we target the kinds of investment they would be willing to make instead of our waiver dollars or our incentive dollars in that way? And then, as we all know, Arcora has been a very faithful investor in oral health in our region, and making sure that aligns with some of their activities. So maybe I'll pause there and see if there are any questions.
What happens when primary care providers paint fluoride on kids' teeth and they're full of decay? Where do they go, and how do you deal with that problem? Because that's that's opening a can of worms, and maybe mom also has horrible decay. And if we're talking whole person care, and we're counting the mind as part of the care and where the dollars go, why is there no oral health, and what do we do about that as a community for that? That's why I sit here.
Yeah, no, I think there's a couple of ways that I would answer that. One, it's going to be up to each of the collaboratives to figure out how they're going to link with the dental community and dental networks that exist. I think one of the things that made this decision slightly easier, though not really easy, was Spokane County being one of the pilot regions for the enhanced Medicaid dental benefit for pregnant moms and people with
diabetes.
Diabetes? Okay. I wasn't sure if it was chronic disease, so it's diabetes. So that'll give us a working group of oral health professionals to be able to link into the collaborative. I think if you look at the oral health project area, it really wasn't going to address that issue to begin with. And so we really think the infrastructure that we're building, whether it's the extremely significant FQHC oral health expansion that has happened over the last 3 years, the dental residency program we expect to come online if the legislature ever releases the capital budget, and then I think there's going to be just some targeted work that will need to happen in that way. But I think that decision really needs to rest with the set of providers engaging at a collaborative level. Is that, it may be insufficient, but I'm not sure it gets to the technical answer.
It's just it's a can of worms. If you go into somebody's mouth and you start painting things, you are liable to deal with that problem. And so you can paint fluoride on all you want, but if a child has infection in their mouth, you've got to address that. And now you have a legal duty to refer them and get them treatment. And so it begins to be a huge issue. If you don't deal with it all the way, then don't deal with it at all and let the experts deal with it. So as a community, and BHT being, oral health being one of your biggest priorities in the past, I ask you as a leader in the community, what are we going to do about this as a community, as people that can make decisions?
Yep, and that's exactly what our implementation planning process will be, is how do we address that. Blake, you want to say more about that?
You're muted.
Yeah, a little bit. I think it's, I do like how we address these issues, with parenting and pregnancy without, taking on the actual, the actual implementation of making it a incentive-based process. Because I think that everything we're going to do, based on what we're looking at in the slides here, is really going to address that population, while we also get to develop these other aspects of behavioral and physical health with them. So I think it's really great.
Excellent. So just, I'm going to keep moving through these. We'll share these slides with you, but I think one of the things that we had a bit of a gulp as we were talking about target population is this going to be enough people to actually have sort of population level improvement? And we're going to have this sort of constant battle of we're accountable to improving the Medicaid population's health, and yet without some level of focus, you can just see we'll be spread too thin. So just looking at some of the prevalence here, I think is a helpful sort of reminder. And then the other piece that I think increasingly is an element to pay attention to is just how is our region doing against the state average of performance measures. And At some point, I'm going to get to come to you and tell you what the actual goal is. We've been told for the last, I don't know, 3 months that they were coming soon. They were coming soon, which will make implementation planning a lot easier when you know where you're actually trying to get to. We are starting to deduce that, you know, the gap to goal is going to have something to do with the state average and trying to move that. And so what you see is in a number of these metrics, of which the region will earn dollars, we're already getting pretty close, if not ahead of that state average, which tells us, okay, that's good. That means the ability to earn the dollars is not going to be threatened by we're the lowest performing region in the area.
Okay. It was just a quick question related to the gap to goal, and I've read it a couple of times, and so I just need to refresh my memory. So when we think about the gap to goal, sometimes they utilize the state average and or the mean of performance, but they also utilize the national benchmark that, or goal that is needed to be achieved. So when we look at the managed care organization expectations within the value-based payment withhold, the idea of the target is related to the 90th percentile for NCQA performance, which is quite high, especially for Washington. So just in clarifying that idea within gap to goal, do we know yet if it's going to be using the goal closure of NCQA, the 90th percentile, or state?
We don't know. My impression is they have not said anything official at all.
Okay, thank you.
Yes, we've got another set of slides that looks at state average versus that. What's also incorporated in other measures, so whether it is Medicare-related measures or MCO contracts and so forth. And we've worked hard to try and make an educated decision about, you know, are you risking performance dollars in years 3, 4, and 5 because the gap is going to be so great? And what we came to was this feels doable for the region as we move forward. So as soon as we have it, though, we're totally going to release it to everybody. Okay, so moving on to the next project area, which is community care coordination, very near and dear to our hearts here using the Pathways Hub. Our target population will be Medicaid high-risk pregnant moms and Medicaid folks transitioning out of jail as sort of our target population to start. I think there's been a lot of good energy in the region to really talk about this jail recidivism rate and how expensive it is for counties and how hard it is for community partners with folks transitioning in and out. So we think that's just a smart population to work with. And then on the high-risk pregnant moms, as you all will remember, Pathways was really launched with that as a target population. So lots of research that tells us that is a smart population to work with, and I think sort of gets to this ability to sort of be a little bit more on the prevention side. So if we're identifying risk factors at the beginning of a pregnancy and helping to work through that, that helps with the health of the baby, as well as just this sort of linking together our focus on ensuring families are healthy. You can see up here again the pay for reporting and our pay for performance measures. This project area has the potential to earn up to $18 million over the 5 years, and we're super excited that in Spokane County that we have just received a Department of Justice reentry grant that'll help support some of the development of pathways for this jail transition. So it both is some additional dollars for us to be able to leverage, but I think probably more importantly, it gives us a really strong partnership with the criminal justice system moving forward.
Sarah, Mike.
Here you go.
Thank you. Hi, Andrew with Excelsior. So this is a really important piece of the total project here for us. Looking at the pay for performance section, and it's speaking line by line to a population of foster youth that are aging out of the system, transition age youth who are homeless and exiting incarceration and hospital systems. That being a very complex group of people to work with that requires care coordination across many public systems, and having the highest number of related organizations and agencies in the state focused in the Spokane region, I would like to just throw out there that we look at putting it as the target population, not only because we have people with decades of experience doing that work, but it's very clear that this is a population that not only needs our full attention, but also is going to be a shoo-in in terms of helping meet performance measures. Can you speak a little bit about
Sure. I think that that was one element that definitely got sort of teed up in our board discussion last week for some further exploration. Certainly, you've got elements of people who might have been in or are in foster care that would be in those target populations. But I think we're really willing to further explore that as a target population. I think one of the things that was really important as we try to build up the Pathways Hub and this care coordination effort is we didn't try and bite off too much in years 1 and 2, where we weren't able to get sort of those core set of partnerships and the core set of infrastructure in place, and that we had some fairness across our rural counties in doing that. But I will be passing on that specific comment into our discussion point.
So just to summarize, I think it's important to look at the population I'm speaking to as sort of the middle ground between these two target populations. And perhaps it might be helpful just to look at, instead of people transitioning out of jail, that we're also looking at youth involved in the juvenile justice system. And then the opportunity to leverage the existing community resources, I would love to help participate in sort of align some of those resources, because quite frankly, if we call it care coordination and a pathway hub model, we can apply that language to many existing groups and really show a really sizable initiative.
Yes. Star next to that, and you're going to have a place to say, I will be part of that as soon as I'm done with my part. Okay, any other questions or comments on this? Oh, yeah. Jim, are you talking about the November 16th submission, or are you just talking about the implementation plan? So how about I comment? We will post our project plan on November 17th after it is submitted. So there isn't, we are not seeking public comment, since we believe that through a variety of different decision-making or recommending bodies, there's been a lot of input into that. I think that there is a requirement as we move to the actual project plan, the implementation that'll happen, or the implementation planning that'll happen in the first 6 months or so of next year, that we would have a community comment portion as part of that.
If I could add one comment to that, I think it's important to note that our November 16th application is actually not as detailed or as finalized as maybe we were initially led to believe, and some folks may think. So in that project plan, we are not required to have our finalized list of partners. It's a preliminary list of who we've been engaging with. We're not required to finalize which models we'll be implementing for the project, so we have to say which project categories we're selecting. We don't have to finalize the models. So this is going to be a rather, we are strategically trying to make this application, I'll say vague, so that we can still get the full amount of money, but still have the freedom as a community over the next 6 months to allow most of these decisions to be made by the collaboratives and made by you all. So in that process, there will be opportunities for engagement, but for this plan specifically,
hasn't zoned in quite enough to be really concrete yet.
And I would add to that without the goal of each of those metrics to meet, it's awfully hard to have a finalized or a very deep implementation plan. And I would say the surprise of 3.5 weeks before the deadline, a 30% cut in funding has a pretty tremendous impact on what we think we can accomplish. So we have always felt like these collaboratives were the place that the work gets done. It isn't the ACH telling the collaborative what they need to do, but more it's going to be our community and our set of providers who are engaged being the folks who are making that that decision in that way. Okay. I feel like we have justified this quite well. I'm going to move quickly through transitional and diversion. I think I'm really pleased with sort of the evolution of how our efforts in this way has played out. One, we have found that there's an element of this work already happening in the region, and there's a just tremendous opportunity to try and scale that up, so it's not quite luck of the draw of where you end up, the kind of support you have as you move through this. We think there's a tremendous opportunity to take advantage of the medication management pilots that are happening all over the region, as well as pathways. It is, as you start to get into these next set of projects, there's less dollars available, so the ability to leverage across existing work and getting to scale is going to be really, really critical. And then I think the same could really be said for diversion interventions. I should note that the target population of both of these will be folks with behavioral health issues as a starting target. I think the thing that has felt encouraging about this is sort of all of the beginning success we've had with Ride to Care, and this opportunity to really think about that and how well we now see it linking with this set. At first we were a little nervous that the way we were defining some of these models, was it going to be a bit too much of a square peg in a round hole, but increasingly I think that is aligning well with sort of community momentum and energy, as well as the ability to link it with this set of projects. I think the other thing to just note on this one is this opportunity for expanding community paramedicine and how we might link that across a number of different sort of funding sources to be able to do that more effectively. I know that continuously is part of the rural health conversation. Opioids. I think this feels like one of the hard project areas for our region. I think we all are in agreement of sort of the epidemic and the just crisis at hand, and the amount of energy sort of surrounding this in the community, and that what is in the waiver toolkit is really linked to some very particular sets of guidelines and work that we need to do. So we're excited to sort of put the check mark next to each of these, and then really use our creativity as a region to start to address that. I think one of the comments that was made in one of our focus groups was, we need to get more comfortable with the stigma that is attached to a lot of this work, and how do we start to have some better community conversation about this? And that, to me, success is not going to be just we're implementing better these guidelines and some of these clinical practices, but we have helped change the conversation overall. I think we have seen already some flow of resources starting to come this way, and that our intent will be at a collaborative level to be able to meet both the strategies and the ability to earn dollars, but really, how do we have a regional plan that allows us to access these dollars in the most powerful way? And then finally, chronic disease. So the target population will be adult and children who are Medicaid patients with diabetes. We are still sort of trying to work through the data side in terms of adding children with asthma. We think there's some awfully cool work starting to sort of connect here in our community. And then we imagine in these other project areas a bit of a crossover with this work with other co-occurring conditions. $5.4 million for now. There still seems to be a little bit of CDC dollars floating down to really support chronic disease and trying to get upstream and doing more prevention work. I think it is safe to say there's a little bit of under siege-ness that is happening at a federal level, but I think the more we have sort of an integrated approach, the easier it is for us to secure some additional dollars. And then I just, sort of run through, I think I've covered most of these elements. I can't stress enough how thoughtful and engaged all of our project selection discussions have been around no one walking away thinking we don't care about maternal and child health or oral health. That would be inconsistent with what the conversation has been over the 3 years of formation of the ACH formation. And we have a structure to sort of work through, and we feel a deep responsibility for how we earn the maximum of dollars for the region. So we think we have some good opportunities there to integrate, and hopefully as the collaboratives develop, this deeper opportunity to be more creative in how we address those issues. So I think with that, I will, because I have 5 minutes still, I will just sort of leave you with this idea that is probably a little bit provocative in terms of, there was a giant gulp, I would say, by some of our board members when I was laying this out, is, with our 6 projects, I think we end up with about 28 metrics as a region we're going to need to earn, or that we'll earn dollars against. And some of them, while it will be an improvement, feels like not quite enough to make population level improvement. So as we've sort of been thinking, like, what's the rallying cry? What is this region going to really get behind that doesn't just sort of improve health, but really transforms health? And so the things we've been talking about are increasing mental health and substance use penetration rates by 50%. We hear over and over and over again the provider shortage, the lack of availability of services. At a fundamental level, it's going to be hard to improve population health if people can't get the care that they need. For all of you who would fall in that, I realize this is a non-clinical person suggesting that. So I would say it's sort of that as a proxy for how do we make sure more people are getting care. This idea of reducing unintended pregnancies, especially for the Medicaid population. How do we create a culture of empowerment and people getting to take responsibility for their health and make choices that are right for them? And then, at a fundamental level, the amount we are spending on the in and out of jail across our counties and our region is pretty horrifying. As a taxpayer and as a person who believes there's a lot of human potential that is not being well served in that the metric that the waiver talks about is % being arrested. I would challenge that's probably not quite the right metric if we have our county jails stabilizing people's health only to have them be released, not having the right set of housing or transportation or access to care that they need available. We could do significantly better that I think you start to then identify these are places there could actually be shared savings so that we are making these upstream investments that I would venture to say most of us is what is bringing most of us to this table.
Hi, Allison. I know time, so I'm going to go quick. Can you flip back to the diabetes slide for just a second? Or the chronic illness? There we go. I'm sorry, I focused on the diabetes. I guess, and I don't really know how to frame this question, but so it might be just kind of a series of observations. But I know with chronic disease, they've done a lot of work in the mental health region as far as looking at like the ACEs study and the relationship between chronic disease and trauma. And I know we're still in very much the infancy of that in the industry, as it were. But I'm kind of wondering, as time goes on and as we go forward with these projects, if, you know, the mental health, because I noticed in the metrics, there's nothing about mental health care anywhere in there. And so I guess I was kind of curious if, as time goes on, we can move that mental health metric down in there and make that kind of an ongoing thing, so to make it more integrated and kind of mush that all together, for lack of a better term. So I guess I was kind of wondering if there's rumblings of that, or if people are kind of aware of that, or kind of where that was at.
Yeah, I think there's a couple great points in there that I would highlight. So the first being, these are the metrics that the region earns money on. And so we don't want the state to add any more metrics there. But what we really envision is that each of these collaboratives will have some elements of all of these metrics, because we're going to have to be moving those as you move through, but there will be some additional ones. So when we talk about reducing jail recidivism rate, that will be an accountability of the collaborative to work with. So I think what you're getting at really you'll see it visible in the overall collaborative, even if it's not specifically tied to how the region earns those dollars. I think you're making a great point of while after November 16th, I hope we stop talking about 6 project areas and we talk about the collaborative structure that is linking healthcare transformation with social determinants of health, because I think if I had better art skills, you would be able to make the link between all of these in a variety of different ways. And they aren't discrete activities. One, because the patient is the same in a lot of these areas across all of them. And if you're talking about whole person care, we want to stop thinking about them as if you could manage your chronic disease independent of managing your mental health or your oral health for that matter. But you're starting to think about who are the patients that are engaged in the system of care. And I like what you're saying of where I think the power of these collaboratives are really going to come from, are having people like you sitting with the diabetes coordinator, who's sitting with the primary care team to ensure, one, we're aware of the sort of evolving set of research and best practices, but also, how do you actually do that? Because I would say in our work, sort of just traveling through, that there's very little disagreement about the intersections. It's just, I don't know what to do with it. Like, I know there is an intersection between this, but if there's not a billing code for me to be able to bill to do something about it, it's really hard to do anything more than like, I just feel bad that I've identified this issue and I don't know where to send you, I don't know how to move that. This idea of the collaborative, we believe, gets to actually not intending to work together, but a structure that would actually drive that working together. Thank you. Okay, I didn't think I'd use all the time. Thanks, everybody.
All right, folks. Okay, so we've got to move into one other quick update and an ask I have for you all, and then I want to jump into a feedback activity. So based off of a lot of feedback that we've heard, both from our scoring process of the Phase 2 certification and the feedback that you all gave at last month's Leadership Council on how we can improve some areas in our application, the board approved this last week the launching of 2 additional councils for BHT, the first being a provider technical council. So that would be a focus for a group that's made up of providers from diverse service settings. So we're looking for substance abuse, we're looking for mental health, social service providers, clinic providers, oral health providers, all the providers. And this would be a group that would give technical advisory to the collaboratives, and I think sort of start to tease out some of those issues, maybe unintended consequences that we might see as providers are trying to link new systems of care. This would be the group that's really asked to sort of vet that and give recommendations from a provider level back to the collaboratives. We are trying to get these groups launched as soon as possible. So one of the asks I have for you today is to help us find who are the right people to serve on these councils. On your tables, and also as what will be sent out in the notes through a survey link, we have a nomination form where we're asking for folks to put forward recommendations of somebody, sorry, you guys have the wrong form. It's the one that says nomination form. Recommendations for folks who you think would add a strong perspective to these groups, and then we're going to go ahead and reach out to them and start to recruit for this. You can self-nominate too if you're interested. Additionally, we are launching a Community Voices Council. I think this came out of, we've got some really strong feedback that while the BHT staff is trying really hard to be out and available to folks in the community and gathering as much information and perspective as we can, that there's some sort of disconnect between how is that work actually really being captured and brought into sort of like into the process of how our projects develop. So to make sure that that's a little clearer, we're going to launch a Community Voices Council, which is going to really serve as our sort of consumer advisory board throughout this work. We want to see this council at least 50% made up of Medicaid beneficiaries or low-income health and social service consumers, as well as folks who maybe are community health workers or care advocates who have some experience working with the Medicaid population and also navigating all of those complexities within those groups. So that's another place where we're looking for nominations for folks who would be strong community leaders in that group. What was that question from Carol? Oh, okay. The link, if you're online, the link's being shared through the comment box. So again, we're going to have that survey link out for a few weeks so we can gather as much feedback as possible. Really for the Provider Council, we're looking for a strong mix of providers from different settings and across the rural, urban, and also tribal facilities. And for the Community Voices Council, I love, we plan to be working with Kathy Burgoyne from Foundation for a Healthy Generation, who has built out some of these engagement bodies for other ACHs like in Pierce and Southwest. And a great recommendation she had for finding folks to recruit is ask the question, if you got sick or you had a crisis and you needed help, who would you call? Who is the person in your community who knows the answers, who is available, who steps up and helps their neighbors? Which I really like that sort of phrasing. So if someone just came to mind, please write their name down. Yeah.
Hadley, just for the Community Voices Council, do you have something built in to support that work for those folks?
I am so glad you asked that. Thank you for reminding me. Yes, because we understand that this council is not going to be made up of people whose day job is to come to these meetings and talk about healthcare. We envision that we'll be offering some sort of stipend as well as trying to offer meals or childcare. All those meetings will be hosted in the evenings after working hours or potentially on weekends based off the needs of the group. So that will look a little different. Similarly for the provider group, we expect that most of those people need to have meetings after working hours because a lot of them are working through the day, so that'll likely look at an evening meeting. But yes, thanks for bringing that up, Nadine. So again, the Community Voices Council is really going to give that input and sort of vetting for all the plannings, but how this fits for consumers, people who are actually going to be accessing these services. And I'm also really interested in building out this group as sort of a body that holds the ACH accountable to some health equity goals and sort of looking and making sure that whatever we're implementing doesn't have negative consequences and that it's also really focusing on the high priority areas where there are a high need for impact. Any questions about those two councils? I'll be sending out the charter and the nominations forms with the notes.
Where are those voices going to be heard, and how will you take that work that's being done in those two groups? How will you put that back into the work that you guys are doing here?
Great question. So we, part of that is going to be in the next section. I'm going to ask you all some questions about what would be the best fit for incorporating that group. But one of the definite things we think is we want a strong connection to the collaboratives so that for both the provider group and the Community Voices Council, there are representatives who are in both on that council and at the collaborative. So we know there's constantly that feedback group, but then also some sort of process whereby as collaboratives are coming up with a plan, there's a, it's scheduled so the consumer and the provider councils will have an opportunity to give feedback and vet that and inform to that group like the implications of their suggested plan.
I would also add that, like we have done with our Tribal Partner Leaders Council, the Waiver Finance group as well, that any major decision that would come before the board would first go through that. The board has been very intent on asking, like, what is the other conversation? Like, we have our set of perspectives, but how is that being sort of looped in? We have a nice visual of these sort of technical groups being able to go deep enough so that they're really the ones driving the policy recommendation to the board.
And who would report to the board on that? Is that a BHT board member, or is that someone actually from the community? Like, I'd like to see a Medicaid lead, like a client actually leading that and giving that message directly to, so that there's not anything lost in the communication. Because I know when we work on Medicaid stuff, we sometimes get detached because we are working on the thing, on the paper, but we're not actually getting that message that needs to be told to the decision maker. So is that lead going to be someone other than people that are working directly in BHT?
So all of our leadership structures are chaired by a BHT board member, as well as somebody either from the leadership council, which would be the case for the provider group. On the community voices, we expect that there will be a BHT board member and then someone from the community. And we would always invite those leaders to deliver the message. Our board meetings are open, so anybody can participate in listening to the dialogue.
And I would add that that's one of the reasons I'm really excited to be working with Kathy Burgoyne, who's sort of like an expert in building out this community engagement work. Something that she's learned in her work in Southwest and in Pierce County was that they saw a lot of success in having community health workers and Medicaid beneficiaries both in the same council, because it sort of added this team approach where you had someone who could talk about the lived experience, and then someone who was a strong advocate, so that if you're a Medicaid beneficiary and we said, hey, do you want to come share that to the board, recognizing that might not be the most comfortable setting, that they actually take a team approach where a Medicaid beneficiary and a community health worker serve together as that sort of lead role, so they can always help each other and kind of work between those two kind of languages, which I thought was a really strong suggestion. And additionally, we've been working with Deanna Davis from Applied Insights, who's been hosting community focus groups with Medicaid beneficiaries in settings throughout our region, and she's been developing a list of sort of best practice. She's not going to have that finalized until the end of October, so I don't have what's on there yet, but that in those groups she's asking very specifically, how do you want to engage, what's your comfort level, like, try to figure out the best practice strategies for how to actually make that group really useful and so they feel comfortable and heard.
So I guess finally just the message, that's really what I'm hitting on, is making sure that that message is delivered in the way that the group actually came up with. So that would be my key advocacy for Medicaid patients.
Mm-hmm. Yeah, I just had a question that you kind of answered about making sure the community health workers were involved, since Kathy was at that meeting that we were at. And then I did have an additional question about, are we talking about setting aside dollars for education of the provider community? Because there are quite a few blockages there, just needs continuing education for those people.
Mm-hmm. Yeah, that definitely is something that is in that collaborative structure. We're thinking about, collaboratives are going to be assessing early on what are the big roadblocks, where are the big barriers that we see gaps for providers, and where the ACH can maybe invest in education. That's definitely something that we'll be looking at. Yes. Yes. We'll be sending stuff out. There are also a lot of resources from the Practice Transformation Hub, which Sean can always help with, but we will be connecting about that.
Just a couple thoughts. One, again, to Andrew with Excelsior. One is the Provider Council Charter. As I was looking through the list, I just got to scan it, but I didn't see what I would consider social determinant of health organizations. And so part of what I'm bringing forward is when we're looking at how some of the investments that we have are distributed, we have 10% of the funds over in the corner for kind of initiatives related to social determinants of health. And when we step back from this whole complex hurricane that we're trying to get through, we know that wellness includes physical health, 3 dimensions of behavioral health, and 4 dimensions of what we call the social determinants. And we know that there is some dependency, there's some cause and effect along that continuum. And so seeing 10% of the investment in this transformation set aside for what really is 50% of how we really engage people in positive lifestyles and things that lead to positive behavior choices. I'm just throwing out there, is that an adequate amount? And then I want to tie that to something as an example. 50% increase of penetration in mental health and substance use services. And I don't think it's ridiculous. I think it's great. But the landscape shows us we're at 46% in terms of having adequate healthcare professionals to meet that need. Is it possible that an increase in the social determinant of health providers, how communities and small neighborhoods can participate in redesigning what a community center is, to get their medication administration there, to get their oral health needs met there, to get their food, clothing, and have hub-type housing? If we're spending a little bit of time reimagining the important role of social determinant of health, we're going to make, I think, a bigger impact and actually hit some of these markers that we kind of look at and say, what? No, I think we can get there, but we have to refocus the direction that we're headed. And so I just wanted to put that out on the table and invite anyone to have conversations about how we can redesign what a community center is for each neighborhood and empower them to design it themselves.
Mm-hmm. Just two quick comments. One, it's 10% is absolutely not sufficient for social determinant of health, and I think it is also important to remember this is a Medicaid delivery system reform project. So there's always going to be a tension point, and that, you know, in my dream world, in 5 years, we will have been successful. Not that we have closed every single gap that exists, but that we have built a community structure that is addressing things exactly as you're describing, and is taking these dollars as a accelerator, an instigator, whatever you want to call it, to actually build a transformed system. And that it isn't appropriate, nor is it practical to think we're going to transform the entire system on via a Medicaid waiver. But what we do know is that Medicare is going through a significant shift in the same way. So leveraging both the investments that would be available as we move into that, or just getting alignment. And we're seeing in the private market an increase in how are you getting upstream, how is the wellness portion of this. So I think it is important to not see the Medicaid waiver as the end-all, be-all, but more as a catalytic experience, and that trying to utilize those dollars at the collaborative level to provoke exactly what you're saying. And I think your examples that you gave would be the ideal thing that we would see out of, as you start to see some shared savings being incurred, could be distributed in different ways. But as we're going right now, the silos are too siloed, and we aren't getting any bending of the cost curve, nor, I would say, significant health improvement happening at this point.
Is it one brief thing? Real brief. I think if we don't make targeted investments now and sort of consider that we have these opportunities later, we miss a really big potential exponential gain. So thinking of eco cycles, thinking of all kinds of things in terms of what we're redesigning, if we make targeted investments early, we'll be able to harvest those on time. If we don't, your only option is high volume. And we know that high volume care hasn't been working. And so to transform something, to create something right next to a high volume system that operates in a similar way is a fear, maybe. Maybe I'm expressing a fear.
I just want to say personally that I have a lot of comments on that, and that if you are around after the meeting, maybe we could chat. And if anyone else wants to sync up on that conversation, I also have lots of comments on the intersection between foster care and transitional age youth. We can powwow in the back by the coffee after this meeting. But for now, I've once again failed to leave enough time for the discussion that I'd hoped for. One day I will learn this lesson, I promise, team. So seeing that we're kind of entering into a new year for the ACH, as we're going to actually start doing things, and a lot of this work is going to transfer more to the collaboratives, who will be having much more in-depth discussion about how these projects are going to actually be implemented. Additionally, I expect that most, if not all of you and your organizations will be tapped into a collaborative at some point somehow. So you all are going to be asked to engage in this work differently next year, and I don't have all the answers about how that's going to look, but that's leading me to ask the question of what should be the role of the Leadership Council moving forward. I think for the last 2 years, it's been sort of, first of all, we're here sort of synthesizing all the information that's coming up from the local bodies. We're trying to be the regional perspective for how we want to transform care. But now this is kind of moving back into we're sort of almost going back to more local in a sense. So I have some questions for you all today that I'm hoping we can take the next 15 minutes to do some small group discussion. And once again, we've got some questions laid out on the table with room for you to write some answers that I'm hoping you can leave behind for us to explore. Additionally, we'll have a SurveyMonkey link so you can all leave comments electronically or throughout the next couple weeks if you need some time to noodle on it. But what I am really wondering, and I already lost my sheet. There we go. First of all, I would like some input on, in the last year, sort of like what's been useful about the Leadership Council meetings. What have you liked? What hasn't been useful? What feels valuable? I think we've kind of had the structure of the first 45 minutes-ish. We have a presentation about some sort of key initiative or key element of demonstration. And then we did, like 45 minutes of updates. Here's sort of the big news that happened this month, big things that are coming ahead. And then we held the last space for a little bit of either activity or chance for us to get feedback from you all on the current thinking. I'm curious if that structure, it felt good, it feels like it's the right thing moving forward, but also recognizing that now we're moving into a stage where we're going to have more, each month as we move along, there'll be more concrete understanding of how these projects will actually roll out. How do you all want to interact with that? Do we want to continue having a monthly meeting where we do a report out? Like, are these 2-hour monthly meetings feeling useful? Is that too much time? Like maybe next year we move more into like webinar updates. I don't know. We're really open, and I'm just trying to see what is the best use for this body. I think additionally, some of the accountability work that we've asked the Leadership Council to do will likely be more formalized in the Community Voices Council, where we're really going to ask them to be a group that is holding us accountable to health equity goals. So I'm just sort of curious about the evolving role of the Leadership Council. I'm here to answer any questions, and our team will be floating around to be able to interact with any questions you might have about the Leadership Council. But now I would appreciate just any comments or thoughts that you can leave on this form or by email or the SurveyMonkey moving forward. Any questions about this ask or the Leadership Council in general? All right, then please go ahead and discuss. Folks on the phone, we're muting the room so that you guys can all discuss on the phone, and you have the SurveyMonkey link, so you can go ahead and give us feedback through the SurveyMonkey. I might ask that some of you at these small tables could join a larger table. And thank you so much.
Hi, this is Jack Davies, and I am very curious as well from Hadley's perspective, and partly as co-chair of the Leadership Council, what your thoughts are on how you would like to see the Leadership Council function going forward. I think we've got quite a few people who have got their phones muted. Hi, is there anybody left on the phone?
Yeah, this is Jim Jackson.
Hi, Jim.
Hi.
Okay, fantastic. We're done.
And
I think it's just hard to kind of think how we should move forward, given 2 minutes to think about it. I could would have been nice to have a little bit of pre-thought to discuss this.
I think so. Maybe what we can suggest to Hadley is that we let people fill out the Survey Monkey, and then maybe we could have a follow-on conversation after we get the responses back and let people have some time to think.
Yeah, I mean, because I think there still might be I don't want to make a quick decision to think, no, we're going to move into the collaborative and we'll all filter into one of those, when maybe there still might be a reason to have a leadership council, and it's just at a different frequency. I think there's some benefit to everyone getting together, because that was partial goal of the ACH, is to get that good blend, and then some organizations may fall into more than one collaborative, and so that can be hard for them to manage.
That's a good point. And I think also pragmatically, there's going to be a need for cross-collaborative communication and coordination.
Absolutely. And I think, just initially, while I can see there's initial reactions like, yeah, let's move into these collaboratives and we don't need the group, but at the same time, are we going to lose the benefit of hearing what the different collaboratives are doing and how that could help transform things that we're doing or bring to light things that we might overlook in the different collaboratives? And so I think it would make all the collaboratives a little bit stronger if there was a structured way for everyone to share information and how in progress.
And if I may, it sounds like someone has some elevator music or some smooth jazz going on in the background. If you could either mute yourself or just turn that down, I think other folks in the group would appreciate that.
I feel like someone put us on hold, and that's their company's hold music.
Yeah, we can only mute and unmute people, so I'm not sure who's got that going on. I'm still looking for it, so you guys continue your conversation.
I think it might be better Health Together themselves have the background music. I'm not sure. So this is Jim Jackson. Are people able to hear me?
Yes.
So, I travel around the state, and I go to all of the ACH meetings, and without suggesting what is right for BHT, I see that leadership councils or RIP councils, they're referred to by different names in different regions, but they largely kind of play that role of synthesizer and convener for the various project areas. And so just kind of things that people have been sharing just now is that they do bring those groups together and perspectives of the groups, and they identify missing links or synergies between the projects that might be missed if the Leadership Council wasn't happening. And then the Leadership Council in some regions, or RIP Council, also plays a role of making recommendations, having some say-so, making recommendations up to the board level. So they have a more prominent role in project development and ACH guidance, if you will. And I think, Jack, you go to the Greater Columbia Leadership Council meetings, so you've probably seen that there.
Yes, and that's a good point, Jim. And, you know, I'm sure that their leadership council is going to be evolving as we move into implementation, but I don't see the need for that kind of, it's a combination of input and updates. I don't see that need for that going away.
Right. Yeah, I think all during the course of the project, I think there needs to be a mechanism for all participants to come together and discuss where they're at and how they're doing in their respective areas.
Mm-hmm. Any other thoughts? Anybody else still on the phone? Not too many. Well, this has been helpful because at least it's helped me thinking about the survey. Yeah. And what comments I might put down on it. And if all of you, I think the survey is down there in the link or down in the chat box. So if all of you could go ahead and fill that out, that would be great.
All right. Thanks, Jeff.
Thank you. All right. Bye-bye.
Bye-bye.
All of your, anything that you wrote down. And again, the SurveyMonkey link, I'll leave it for at least 2 weeks so that we can gather some feedback for a while, because I really want to make sure that next year's meetings are like the best use of our time as possible. So does anyone have a report out from their table that they're comfortable sharing?
Thanks, Hadley. We actually were challenged with some what are seen as deficiencies as opposed to having a total solution to that. The deficiency is that we here don't necessarily hear from the ultimate consumer, the targeted population directly. And one of the things that I suggested was what's happening with our board meetings, where we have a designated time before the meeting where we simply listen. Anybody can come and speak and talk and share ideas. So we also recognize that very often the population we're targeting aren't comfortable coming and talking in front of us, but per what you said earlier, having somebody with the case manager come and present, maybe there's a dedicated time during the meeting to do that.
Are there other comments from the group, Kathy?
summarize what our table talked about. First, we wanted to say what we value here is hearing all the different perspective and the different voices, because we work in our silos sometimes and we don't hear that. So we see that as a value. We wouldn't want to lose that. And then we see more opportunity even, or a way to have smaller groups work together so we can be even more collaborative. And then at the same time, kind of asking about the sequencing and, you know, cadence of these meetings. We thought as the collaboratives are beginning and the projects are beginning, people will spend more time, you know, going deeper in that. So maybe as a leadership council, these meetings are more as you get a summary of what's going on in those collaboratives or projects, and maybe moving the cadence to perhaps quarterly or every other month. So people have more time on their plates to go deeper on other things.
Can I get a show of hands? Who feels like next year we don't need to meet monthly? All right, about half. Like, okay, that's just good. Good for me to soak in. Any other comments?
I think our table was had some questions about not meeting monthly just because of the level of interaction that we have within these groups to get the updates and summaries. And so just, I think, figuring out that balance, I think, will be important. But I do think that there was a lot of, people saw a lot of value in the ability to continue the Leadership Council meetings to ensure that there is sort of continuity and connection around the work that's happening with the collaboratives. And as we start to form other committees, the ability to sort of pull forward how that work is connected to the structure of decision making, and so just the role of the Leadership Council in being informed and informing that in the future.
Just one comment. Everything today, not once was the aging population mentioned. And there are many people who are eligible for both Medicare and Medicaid who are in the aging population. And so I just wanted to remind the entire group that we need to deal with all of our population when it comes to this.
All right, being conscious of time, I would be happy to adjourn this meeting. I got nowhere to go, so I'll be around for anyone who has more questions or wants to have follow-up conversations on anything. My intent is to sort of send out sort of a summary or some feedback on here's what we're thinking about for meetings next year, and continue to get more feedback from you all on what would be the best fit. So thanks for getting that conversation started, and I hope you all have a lovely Wednesday.
Hadley, do you want these placed somewhere?
Yeah, you can leave them on your table. We'll pick them up. We are overdue for it. We tried to get it coming up. Yeah, we're overdue.
Yes, we're short of opportunity.
You want to walk? I was involved in the Extra Ohio State.
You've been involved in the you guys are a little bit. Yeah. So through that work, we are talking about the cost report.
Right.
You're building tiny house? Right. So, because that group, you know, it looks like they're going to get something.
Well, I mean, if it works, then all those workers
we are definitely I'm the best. I mean,
In our electrical program,